Good evening, everyone, and welcome to our first session in the Women's Health webinar series, Menopause Update. My name is Helene. I'm the Workforce Development Officer here at Western Victoria PHN, and I'll be facilitating this evening. Alongside me is my colleague Jade, who is also in Workforce Development. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm dialing in from Wadawurrung country this evening. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations people and organisations. Just a little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel, and the link to that is on the screen at the moment. And also, if you could see our upcoming events on the screen, you can register for these via our website, and the link to that is on the chat there. A special mention to our upcoming education dinners for GPs and practice managers in Warrnambool, Ocean Grove and Hamilton, where you can enjoy the complimentary canapes and sit-down meal with your colleagues. And the registration link is in the chat for you. Please make note of the West Vic PHN health pathways relating to this topic, that it's on the screen at the moment. Most of you should be familiar with our health pathways. If you're interested in learning more about menopause, Jean Hales for Women's Health has developed an online course titled Managing Menopause in General Practice for GPs in partnership with the Australian Menopause Society. This RSCGP accredited course is designed to help GPs stay up to date with the latest evidence and to feel confident with providing patient-centred care. In addition to this, Jean Hales has developed a separate course for nurses and midwives on the topic of understanding menopause. This course aims to help nurses and midwives improve their knowledge and understanding of menopause, including key management principles. Other health professionals are also welcome to participate in this course. Now, West Vic PHM will provide a certificate of attendance. If you could take a moment and check that your full name is displayed accurately on the screen. If not, or if you're unsure, just rename yourself or type your first and last name in the chat box. This way that we can ensure that we can get your certificate to you. This event is being recorded, so please keep yourself on mute unless you would like to ask a question during the designated question and answer time at the end of the formal presentation. We encourage interactivity and discussion, so please feel free to type questions in the chat box at any time, and I will ask them on your behalf to the presenter at the end. Your feedback is important, so please take the time to complete the event survey after the webinar. There is a link in the chat box to complete that. So welcome to our presenter for this evening, Dr. Sonia Davison, Clinical Fellow, Jean Hales for Women's Health, past President, Australian Menopause Society. Thank you, Sonia. I will now hand over to yourself.
Very nice to see everyone tonight. And hold on, let's get this ready. Okay. I'm talking about menopause and the role of hormone therapy tonight, but I'm also going to touch on other areas. It's not all about hormone therapy, but I'm going to tell you that menopause is literally hot. So menopause is in vogue, literally and figuratively. You can see that image there from People magazine. When I was sitting there at the hairdressers, you open it up, of course, you browse, and this is celebrities who've talked about menopause. So menopause used to be taboo. We weren't allowed to talk about it. Well, we were, but we didn't. It wasn't sexy. It wasn't interesting, and we used to hide away around the time of menopause. But I think because of the pandemic and because of quality of life and because people are better at talking about health, and maybe the Me Too movement, women have sort of grabbed menopause, which is where you have a really key role, and I do, because we're here to educate people. There's a lot of misinformation out there, and there are a lot of so-called experts who are labeling themselves as being experts but have no expertise or might want to be selling a product, so they're after a monetary gain. But women are keen for information about menopause, and they do trust you to give them the information. So hence I'm trying to fill in any gaps if there are any present. But there's information overload. This is a Google search looking at menopause, just that one word, and you'll see there's millions and millions and billions of hits. So it's very difficult for the average consumer, let alone a health practitioner, to try and sort out what's the good information and what's the not so good information. And I'll try and highlight resources that I think are useful in this area. So the patient comes along with the perspective on the left, usually. They have symptoms that can be debilitating. They affect quality of life, and that's why they're sitting with you, their trusted provider of health and information, and they want to know the benefits and risks of management strategies. And they also, if they're really switched on, want to plan for good health in the future. You on the right side, unless you're a patient yourself, of course, which does happen with all of us, have a perspective of, I've got to look after this person. What are the strategies that are about and what are going to be helpful? What are the risks and benefits of those? What is an individual person's comorbidities and their future health risk? So this is midlife, and this is a sliding doors moment where you can really plan for the rest of that person's life, thinking that the average woman will come to you with menopause around 50 to 51. It's a good time to do screening and general health measures, but whatever you talk to them about will depend on the education of that person in front of you and their psychology. They might understand it, but they might not be able to activate the right pathway that would really help their health a lot. So that's another part of our very complex role, trying to do that as well. Perimenopause is where I'm going to start this conversation because it gets very messy, and there's a lot of conversation about perimenopause and menopause about at the moment. But this is an umbrella term. It's the time from when symptoms and signs of approaching menopause begin, but it also covers 12 months after that last period. Because remember, periods might become very infrequent, 3 months apart, 6 months, 9 months, etc. We can only really say that menopause is had once there's 12 months of no period, because if you call it when they've only had 9 months of no periods and then there's another period, then they're still perimenopausal, and people get quite confused about it. The median age of perimenopause is 45.5 to 47.5, so typically late 40s. The mean duration is just over 6 years, but it can be 11 years. So if someone was designed to have menopause, programmed in their pituitary to have menopause at 51, you can see there that they may start to have symptoms from even 40. And even for some women who undergo menopause normally at 45, that might be in their mid to late 30s. So just be aware of the typical symptoms when it comes to women in their late 30s and 40s with regard to perimenopause. Cycles become irregular, they may change in volume, they may get heavier, lighter, the pattern of flow may change, and the hormones are all over the place. I often call perimenopause a beast. Some women don't know if they're Arthur or Martha because one day they're fine or 1 month they're fine, the next month they're getting menopausal symptoms, then they might have a heavy bleed out of the blue, and it's very very difficult for some women to get through perimenopause unscathed. But we also need to talk about contraception because approximately 1/3 of cycles are still egg producing. So we don't necessarily want to have children when we're 47 or 49. But because the pituitary is trying so hard to get the ovaries to make eggs, those messages are amplified, and the chances of pregnancy when you've got 1 in 3 cycles that are ovulatory are still there, believe it or not. It's a difficult discussion, but it needs to be had. So what is menopause? It comes from the Greek. It's just the last natural period, but it sometimes gets clouded. For example, if there's a levonorgestrel IUD in situ, or if the woman has been on the combined oral contraceptive pill and stops it at 50, there's no further periods. Sometimes we just don't know when it is. So we use 12 months of not having periods to say that, yes, someone has definitely gone through menopause, unless there's a very unusual other cause of that. Natural menopause will all undergo if we get to the right age and we're healthy and well. Surgical menopause is removal of both ovaries, and that often used to be at the time of hysterectomy. Sometimes it's for cancer risk reduction these days, endometriosis as well. And those women can be menopausal at a very young age. But it's all programmed, as is most of our health. The average age of menopause, 51 years, but 45 to 55 is normal. Some of my ladies are even sneaking in a bit later than that at 57 or 58, but the median in Australia is 50 to 52 years. We lose that cyclical egg production and we lose the cyclical production of estrogen and progesterone. So this is a little scratchy. I'm sorry for the quality, but I haven't found a better image that shows what happens here. So at the start of this graph here, the period is here on the left. So the start of the cycle, the follicular phase. And in the middle, you can see the follicle developing. And in the very middle, you can see ovulation occurring. But what I'm highlighting here is at the estradiol level, and we don't need to check levels for perimenopause or menopause. I'm just giving you the story here. And many of your patients will want levels checked and you won't need to do it, but we'll talk about that possibly in questions. The typical estrogen level at the start of period is 150. It will depend on the various assays around town, but you can see there with that big spike in the middle before ovulation, it gets to 1500, 10 times higher. There's a sharp fall in estradiol, and then there's a sort of bump in the luteal phase at the end. And if the pituitary and the ovaries are working, and if there are eggs, a woman will do this on average from 13 or 14 years up to about 52 years, but it becomes a bit hit and miss from the late 40s, as you've just heard. The average estradiol level, if you flatten that curve, is around 400. But after menopause, a typical estradiol level, and this is the main estrogen that's active biologically in women, is 20. So it's a 20th of the average. It's a 7th of the lowest level when women are having periods, and it's a 70th of the peak levels that they were used to. So this is why some women really get symptoms. Many do get symptoms, but some get symptoms that are quite severe and debilitating. It is very different hormonal situation than they were used to for the last maybe 30 years. So what about the symptoms? 20%, it's like a walk in the park. They have no symptoms. And they're a little bit cruel sometimes to their peers because they don't get it. They just sail through this. They don't understand what the fuss is about. But they also might not make an appointment to see you, to have their screening done, to get their mammograms, etc. So they might get a little bit lost. Whereas 20% have severe symptoms. They can drench a beach towel overnight. They can have severe mood symptoms and want to, put themselves in front of an oncoming tram because they feel suicidal, or they have such anxiety, or they're so cranky. So 20%, I've got a lady in Moe who slept with the door open. She had a security door, of course, in winter where it gets very cold there. I know some of you are from very cold places, but that was the only way she could sleep, with that very cold air coming in, because she had such terrible symptoms. But 60% get mild symptoms. All up, 80% of women have symptoms that will bother them in some way around perimenopause and menopause. These are quotes from my patients, and I like using them because it makes it a little bit more human, I think. And I really didn't take much note until I started writing them down. I thought, oh, I don't want any of these. I feel dry. I feel old. I feel shriveled. I don't feel like me anymore. I can't compete with my work peers. I can't be bothered to try and get a new job. And I'm worried about the impact on my relationship. And some ladies also say, I shout at my children or my family. Well, families and children are naughty at times, I'll give you that, but it's a woman's ability to cope with her own biological changes and these external forces. And we're living a tricky life. It's tricky times in this world, and there's lots to do. And a woman typically at menopause will be at the peak of her career. She'll have aging parents. She may have dependent children, and she'll be the meat in the virtual sandwich. So what are the symptoms? These are the typical menopausal symptoms that many of us will be aware of. I've highlighted them in different colors to show the nuances here. So flushes and night sweats, which can be drenching, and many of my women sleep on a beach towel, wring it out, and then put another beach towel. So it's not just feeling a bit wafty and a bit hot, although you'll often see people doing that. Urinary incontinence, urinary frequency, and lowered libido. And that can be really distressing for some women if there's a change in them and not in a change in their partner. But the next round of symptoms, sleep disturbance. And I often say I think the sleep disturbance is half of the menopausal bother. Not able to initiate sleep, waking up at that sort of menopausal hour at 3 to 4 a.m., waking frequently, waking hot. They might not even wake hot, but they might wake frequently. And I think this is a really big issue. And some women, as you're aware, and you might not sleep yourself, just don't sleep very well. The next type of symptoms are mood symptoms. So anxiety. So I've had some women who just very irrationally, one lady she was a horse rider, but she was too anxious to get on her horse, which, that's bad, isn't it? She's done it all her life. Another few women have had driving anxiety, so they won't get in the car and drive anymore. So it's a real amazing that a biological normal process can lead to these symptoms, and we're the ones dealing with them. But also mood swings, particularly through perimenopause, depression. So if you're seeing a new onset depression in the 40s or 50s, just be aware that hormones might be playing a role here, and crankiness and irritability can be very marked. And the family might come and tell you about that, or might be too afraid to tell the lady. But also cognitive challenges. So memory loss, lessened concentration. They might think that they're getting dementia because they might have a family history such as mum with dementia. You can reassure them that most of the time this is just 20% of women are having these debilitating symptoms, but they're not likely to go on to get dementia. But of course, it's important to counsel them and get some good information. There's a beautiful information sheet at the Australasian Menopause Society, which can be quite comforting on menopause and cognition, but there's about 30 other information sheets if you're searching for information. And fatigue. Some of these women, whether it's the sleep disturbance, the mood disturbance, whatever, the family life, they just feel very tired. And the last thing is menopause can hurt. And I'm not saying that everyone is going to get all of these symptoms. Usually women have a sort of a little selection of these symptoms. They don't choose them. It's not like tick the box if you want them. But muscle and joint aches and pains, and it can make them feel very old and like they've got a florid arthritis. And that last word there is formication. It's a feeling of crawling or itching under the skin like ants. It can be associated with restless legs. It can be quite debilitating. So again, just remember if someone's coming in their 40s or 50s with muscle and joint aches and pains and you think, oh, there's something exciting going on, it might just actually be menopause going on. What are the consequences then? Well, on the left of the slide here, you can see what will bring a woman to you. She'll worry about flushes, sweats, not being able to sleep, not being able to work, the impact on relationship. She'll worry about vaginal dryness and urinary symptoms, sleep disruption, and mood changes. And more, women are very aware of this because there's a lot of information out there, which isn't always good quality, about menopause and what it means, and also altered sexuality. So it's important to ask women about these things. But the long-term things are on the right. This is when you're counseling someone about their menopause, diagnosing it, treating, giving them options. You're also hopefully thinking about long-term issues such as cardiovascular disease and stroke. What's that individual risk for that woman? Osteoporosis and fracture, dementia, cognitive decline, Alzheimer's, and maybe other processes that we haven't really linked in that we know increase in prevalence after menopause. So the importance of research. So what is the guts of menopause management? Well, we need to make the diagnosis. That's pretty easy sometimes, but again, many women will want their hormones done. If they're a typical age and they're a typical time in life with typical symptoms, you do not need to do hormone levels. Premature menopause, menopause less than 40 years, yes, or if it's an unusual story, absolutely. But symptom control is the next part of it, and also disease prevention, trying to get that person at midlife in front of you to have a healthier future. It's sort of exciting that you can look at it in that way. And there are many interventions that we can do at midlife that can actually help their future health. And governments now are getting on board and wanting us to do this, hence the amazing amount of money that the New South Wales received to make these so-called menopause hubs. So the diagnosis is really made on history, typical age 45 to 55 years, but for perimenopause, remember it might even happen in the earlier 40s. Flushes, sweats, vaginal and urinary symptoms, the body symptoms we went through, the joint aches and pains, the crawling under the skin, poor sleep, mood disturbance, cognitive disturbance, all of the symptoms I went through before. There's beautiful menopause check sheets. There's a lovely menopause score sheet on the Australasian Menopause Society website. And I love to get the women to do a score and then to come back, whatever intervention I've done, and score again to see if it's been a success or failure. It can sort of objectify it, which is useful, I think. And again, we don't test hormones unless it's an unusual situation or premature menopause, which is a small subset, it's 0.3%, but those women do have a higher risk of cardiovascular disease, osteoporosis and fracture, and dementia if we don't treat them with some form of hormone therapy. And I acknowledge that sometimes we're not allowed to, they've had a breast cancer or whatever, but they're a very important group to look after. And they might escape you because they might not have periods and they might find it very convenient to not have periods, but it's important to identify them and to make sure they're educated about premature menopause. So what do we do with symptoms? Well, the big thing about hormone therapy and all of the problems that happened with the big WHI study, which was first released in 2002, is that it made us think really, what are we doing at menopause? What are we doing with symptoms? Were we using hormone therapy too much? We treat symptoms when they are bothering that person in front of us, and we target the treatment to the symptoms. Lifestyle measures are very important. There are non-hormonal options as well, which include medications and non-medical options such as cognitive behavioral therapy, hypnotherapy, etc. And there is hormone therapy, which used to be called HRT, hormone replacement therapy, and is now tending to be called MHT, menopausal hormone therapy. The concept of replacement sort of was not palatable to some, but I think most of the public and most of medical practitioners know the term HRT, so it gets very difficult. But hormone therapy might also include vaginal estrogen, and there are two types of that. What about lifestyle measures? Well, by the time that a woman has come to you, she'll mostly be doing these, but it is important to talk about it. Avoid overheating, and that's for some women who might be police officers and have the occlusive garments, theatre nurses with those, they're all in the scrubs and the gowns and everything. Those situations can be very difficult when they can't control the environment well. So avoiding overheating, dressing in breathable fabrics, cottons, etc., avoiding polyesters, avoiding alcohol excess because that will trigger symptoms, and spicy foods, having a healthy diet, having regular exercise. The healthy diet might include phytoestrogens, which is what we think protects Asian populations from having lots of flushes and sweats. They're getting the soys, the lignans, those healthy content, and we think that actually is giving them an estrogen-like effect, which is protecting them from some menopausal symptoms, which is fascinating in itself. But also stress management. Stress tends to make menopause symptoms worse, and the whole experience and sleep and all the rest of it. I know stress management, it's easy to say, very hard to do, but again, that's part of our tricky role. What about non-hormonal options? There is a beautiful book by Myra, M-Y-R-A Hunter, a UK author who's done a lot of work in this area on cognitive behavioral therapy. It's a self-help book. It's got a very merry cover. You can easily find it on Amazon and other searches if you're interested. I wasn't a real convert until I read the book and I thought, this might work and this is pretty easy to do. So it's just training the brain to deal with the triggers of menopause and to deal with a brain's response to those. It doesn't reduce flushes, but it will improve the dealing with it. Hypnosis is brilliant for sleep, for mood, and also for control of flushes. So if you've got a hypnotherapist, if you are one, that's even better. But if you've got a hypnotherapist in your area, that can be very effective. Acupuncture, the studies say half of them say it works, half of them say it doesn't. But again, an individual who can do acupuncture and who's benefiting that lady, I'm all for it. Complementary and herbal products are out there. The only one in studies that's shown a benefit compared with placebo is black cohosh. But again, lots of people are making money in this market. But black cohosh can take the edge off symptoms. It won't settle really severe symptoms. And of course, there are non-hormonal medications as well. So I'll go a little bit more into these. With cognitive behavioral therapy, have a look there. Improvements in 80% regarding the bothersome symptoms and improved anxiety and improved mood. It is actually very useful for sleep as well. Hypnotherapy, as I've said, can benefit sleep, mood, and also dealing with flushes. Mindfulness, it's a bit hit and miss, and it depends who's doing the mindfulness. I think it is a hard thing to get women to really focus on, but it can be useful to decrease hot flush severity. You'll see from that one study, and significant improvements in quality of life, anxiety, and sleep quality. So really, this is not giving any medications. It's just altering the brain and our responses to triggers of menopause, which is pretty amazing, isn't it? If we can do that, why not? But when we're looking at natural options, as I said there, black cohosh has a minor benefit, a greater effect at higher dose or with St. John's wort. There are minor adverse effects. We were quite worried about a liver risk that was mentioned some years ago. There's been a meta-analysis now that really has debunked that, although just be very careful. And the study data for safety only goes to 6 months. They use a lot of black cohosh in Europe and in Germany, for example. Soy and plant phytoestrogen products, little benefit from taking a supplement, but certainly beneficial taking it within diet. Soy within diet is good for blood pressure as well. Vitamin E, small benefit from some studies. Flaxseed oil is out there, but evening primrose oil, ginseng, wild yam, etc., all fail to show a benefit. So from this slide, black cohosh is really the only one that's really going to benefit them. But they will want something natural and they will seek that. And just remember that bioidentical custom compounded hormones might be marketed as natural, but they are not natural. And I'll go through that as well. So non-hormonal medications, there's a number. Clonidine is up there to start with. As you know, it's a migraine preventative. It's also an old blood pressure agent. We used to recommend this for flushes and sweats until the biggest menopause society, North American Menopause Society, have reviewed the evidence and have actually said it's no longer recommended for control of vasomotor symptoms. It may help still with migraine prevention. It may help some women with flushes and sweats, so I haven't discarded it, but it's quite tricky when there are only 2 TGA approved vasomotor symptom control treatments in Australia, and that's one of them. So I think they need a bit of updating. Gabapentin can be very useful if they've got sleep disturbance, flushes, and pain. And if you can't use hormones, gabapentin, but I always just very gradually increase the dose. I start from 100 milligrams once daily, and I build that up very, very gradually over time. I give them a schedule to do that. And I just warn them to stop at whatever dose seems to be effective. They don't need to keep escalating it if they've got to a good place with their treatment and they're on, for example, 200 milligrams twice a day. The antidepressants, so these are all treatments that we serendipitously found that when we gave them, they were good for their own purpose, but they were also good for controlling flushes and sweats and other symptoms. So the SSRI and the SNRI group are very useful. We recommend avoiding fluoxetine and paroxetine if they're on tamoxifen for breast cancer, because that will inactivate tamoxifen. It won't make it do anything bad, but it won't be effective. Escitalopram, I think, is the treatment of choice at the Royal Women's Hospital Menopause After Breast Cancer Clinic. And there's venlafaxine and desvenlafaxine. You have to remember that some women will have an idiosyncratic reaction to these products and will have an increase in flushes and sweats. So that's another thing to tease out with women, especially if they're presenting, say, 70 or 65 plus, and they say, oh, I'm getting menopause, I'm getting flushes and sweats. Just have a look at their medications, because if they're not typical menopausal symptoms, if it's all body flushes and sweats, if it's a later onset and they've already undergone menopause, I'll put my money on it that it's another process going by or one of their medications. Oxybutynin, interestingly enough, has been used for control of flushes and sweats. Of course, it is quite drying. Of course, it can be an issue when there's cognitive impairment, so just be very careful. And fezolinetant is our new option, which is blocking the hypothalamus temperature control pathway. So when we have estrogen is favorably blocking the effect. So neurokinin is trying to stimulate these neurons in the hypothalamus, which activate the hot flush pathway. Estrogen is nicely abutting them. When we lose estrogen at menopause, it's just the neurokinin B pathway, the nerves hypertrophy, and the hot flush sort of symptoms and the sweats become overwhelming, and they occur at a lower temperature. But fezolinetant blocks that. It's a neurokinin 3 receptor antagonist. So whereas the neurokinin 3 was pushing, the fezolinetant is blocking rather than adding estrogen. So it's been a timely reminder of how estrogen actually works to control flushes and sweats as well. But that is now available as a daily tablet, 45 milligrams, and I can talk about that if you wish to. But there's lots of information out there. So if you need some information, the Jean Hales for Women's Health has got lots of information, but also the Australasian Menopause Society. So these are some information sheets on non-hormonal options for menopausal symptoms. One of them is quite wordy. Another is a nice reduced word variant, which is quite useful for patients. You might like to read the wordier one because it goes through this area very, very objectively, evidence-based. And since I've recently reviewed it, it's now got fezolinetant on it as well. So it goes through, and it goes through cognitive behavioral therapy too, the role of non-hormonal options that aren't medications. Monash University, Professor Susan Davison and her team have updated their practitioners toolkit on managing menopause, and it has a beautiful algorithm. It's a bigger document. It has lots of references there if you need further information, but it goes through what's perimenopause, what's menopause, takes you through that beautiful algorithm with treatments, with doses, and with considerations for other options to use. So it's a really brilliant and well thought out document. So what is the role of hormone therapy? Because hormone therapy is very sought after at the moment. You'll probably have seen that patches are hard to get in all the different strengths, and really women are searching for more information. It's probably because menopause is literally so hot that there are many more women seeking hormone therapy, and our existing resources can't cope. And I don't think the patch manufacturers are ramping up their production because I don't think they make much money from those patches anymore. So I think that's how it works, but that's purely my opinion. But hormone therapy is the most effective treatment for menopausal symptoms. And this is a powerful statement, the next one. Experts and expert societies have narrowed it down to this one statement, that the benefits far outweigh the small risks in healthy women around the time of perimenopause and menopause. And that can often be a very powerful statement to just spell out to a woman who you can see would benefit from hormone therapy, but is just too worried about using it and potential side effects to actually be able to initiate treatment. So the benefits far outweigh the small risks. But there is a slightly increased risk of breast cancer after 5 years of use, and it's very important to counsel women correctly about that and point her in the right direction. So hormone therapy in a nutshell. Multiple trials support a safe window for prescribing, so not doing it from 70 plus, but doing it around 40 to 60 years of age when women are freshly menopausal. Timing of initiation is usually less than 60 years or within 10 years of that last period, remembering that some women will be menopausal at 57, so it might be 67, and younger women are more likely to be symptomatic, have lower background risks for clots in the lung and clots in the leg and stroke, and are more likely to derive a cardiovascular benefit. So it's a nice little one slide for what's a very complex area. But there's also a swinging pendulum here. And these authors who've been presidents of the International Menopause Society and one from the Australasian Menopause Society have written that we're sort of, in a way, negligent if we're not offering hormone therapy around the time of menopause, because they're not only going to get a symptom benefit, but a cardiovascular and a bone health benefit as well. So if we're not offering it, we're in trouble. Whereas in the last 20 years, when we've been offering hormone therapy, we've been perceived to be in trouble because of the outfall from the WHI study. So I'm just going to highlight the deaths from major causes in Australian women. This was in 2022, and you can see there that for the first time, dementia was the most common cause of death in Australian women. 92,000 women died in that year. But if you take coronary heart disease and stroke together, they are the biggest killer. So vascular disease is the #1 killer, but dementia is the sole killer. But have a look at the other causes there, lung cancer, even in those women who don't smoke. So these are the things that will kill people. So again, at midlife, if we can intervene and make a change 20 to 30 to 40 years before someone is no longer going to be in this world, at median age 84.7 years in Victorian women, we can see that we can make a big impact with the things that we can do at midlife. And this is the dementia projections. You can see there the women are at the top, up to 2056, and it's really terrifying. We don't have really good treatments for dementia at all, and the governments are realising that anything we can do to prevent it or delay it for even a little bit will be beneficial. Women do get a higher rate of dementia, whether it's because they live longer, and we tend to get more Alzheimer's disease as well. So it's just scary. Those things are scary, aren't they? But this is another slightly scary thing. Women are always at higher risk of bone density decline and fracture because they have less bone than men do. But you'll see that we reach that fracture threshold a lot earlier than men do, and it's brought down by menopause, which is happening there with the purple arrow at 50. So the lifetime risk for a hip fracture is 16% in Australian women, but you've got to remember that a quarter of women die in the year after having a hip fracture, which means they were probably old, they probably went to hospital, they probably got a complication. But again, we want to avoid fracture and we want to avoid osteoporosis if possible. So what about dose, delivery, and regimens of hormone therapy? Do they matter? Well, yes, they do. Low dose has less effect on thromboembolic risk and less effect on breast cancer. Transdermal, less effect on thromboembolic risk and stroke risk as well. Estrogen only, less effect on cardiovascular risk, less effect on VTE risk, and less effect on breast cancer risk, and also colorectal cancer risk reduction. So the good thing about WHI is it did show us that combined hormone therapy, estrogen and progesterone, actually lowered the colorectal cancer risk. We don't know how or why, but that was very interesting. And also, not all progestogens are created equally. And we now know that micronized progesterone, which is the product prometrium, rather than a custom compounded one, and dydrogesterone, which is found in the combined product Formostin Conti, and the 1/10, 2/10, they're closer in structure to body identical progesterone. Micronized progesterone is the same as body, the progesterone that our ovaries produce, but they also have a lesser effect on breast cancer risk versus the androgenic progestogens, such as medroxyprogesterone acetate and norethisterone acetate. And we now know that from a number of studies. So this is looking at the risks and benefits of hormone therapy within that time that you'd be likely to use it. So within 10 years of menopause or with less than 60 years of age. And if you look at this graph, the black line is estrogen only, Oh, I'm so sorry. Let's keep going on. And the white line is estrogen plus progesterone. You will see here on the right of the slide if there's a benefit. Looking at the vertical line, the horizontal lines to the right will show there's an overall benefit for symptoms. And if you look at the risks, they're a blip on the radar down the bottom there, looking from fractures to cholecystitis. But the next slide is a blow up of the bottom of this slide. And this is produced by the US Endocrine Society, who looked at all of the major studies. It wasn't just WHI, looking at all the studies, looking at all the risks and benefits for women who you would typically prescribe hormone therapy to from 50 to 60. So this is a blow up of the bottom of the previous slide. Estrogen only is the black bar, and estrogen and progesterone is the white bar. So I'm going to take you from the top to the right. So you will see there are less fractures, diabetes protection, which I can't really understand, but it's fascinating, less overall mortality and coronary heart disease for estrogen and progesterone. That's clearly there. But where there are some differences, you will see in the black bar with breast cancer, estrogen alone actually had a reduction in breast cancer up to 7 years of use in the WHI study, whereas there was an increase in breast cancer with estrogen and progesterone over 5 years of use. It was a slight increase, not up like a rocket, just a slight increase. The main issues, however, were at the bottom. So VTE stroke, which is a low incidence in this healthy age group, and cholecystitis is the outstanding increased risk. So in terms of counselling someone about risk, it's important to be aware of these risks and the benefits and try and highlight that there is some excellent information. The Australasian Menopause Society has a beautiful information sheet on MHT benefits versus risks. And that's pretty easy to find online, and it's beautifully written, so well worth looking at if you need that guidance. So, having said that, I've now happily enough come across the sheets that I've put into this presentation. I love the infographics on the left sheet. That's we're meant to be using videos now and pictures rather than words, but of course some of us like words. I'm still liking words, so I will look at the risks and benefits of hormone therapy on the right, but the one in the middle satisfies both camps. There's words but less of them, but there's some lovely information out there. So just it's a matter of getting familiar with it, clicking on it, asking the lady to read it. You can't do everything for everyone, especially in our short appointment times. We've got to get them to do some homework. And this is a really lovely guide to hormone therapy equivalents. So it goes through what's on the PBS, what's an estrogen only, lower dose, middle dose, higher dose, what's a combined product. And it's very handy, given all the patch shortages, to just have a look and say, oh, well, there's actually oral estrogen at low dose. You could have this, or there's this gel or the other gel. So have a read of that. Have it in the just online that you can click it, or have it in the drawer. It's very useful. There's also one for New Zealand if you practice in New Zealand as well. So what are the contraindications to hormone therapy? Well, if you have a look on the left, the relative things, if you think of the typical woman you prescribe hormone therapy to, many of them have these things. So hypertension, benign breast disease, fibroids, migraine, gallbladder disease, endometriosis, past VTE, familial hyperlipidemia, chronic thrombophlebitis. I think you can think that almost every woman who you consider for hormone therapy has any of those. But if it's controlled hypertension, if it really is just benign breast disease and there's no nasties there, if the fibroids are under pretty good control and they're not too bulky, if their migraine are again under control, there's no contraindication that stops you from using hormone therapy in those women. If it was migraine, I'd probably use transdermal rather than oral. And past provoked VTE, the US Endocrine Society say we can still use hormone therapy. It's when it's unprovoked or a thrombophilia that you might need to get guidance. But on the right of the screen, absolute contraindications, active acute liver disease. I'm not saying fatty liver. That's we're looking at a bigger escalation than that. Chronic liver disease with impaired function, breast or other hormonally sensitive cancers, so some endometrial and some ovarian cancers are hormone receptor positive. Meningiomas are hormone receptor positive in some cases, so just be aware, get advice and guidance. Sickle cell anemia and thrombophilia. Again, you may want to use hormone therapy in thrombophilia. Just get hematological advice. And of course, it's easier if they're on a blood thinner. It's an easier discussion. So breast cancer risk, this is the biggest hurdle, I think, for practitioners and for women. And we know that 1 in 7 women over the age of 50 years will develop breast cancer, and no one wants cancer at all. No one wants to get breast cancer, and everyone is very frightened of it. But we've got to take it into context. So hormone therapy is associated with a similar risk of breast cancer from study data as consuming 2 alcoholic drinks per day. The major risk factors are a family history and having dense breasts. And I know it gets very tricky because sometimes these risks stack up a bit. From the largest hormone therapy study to date, which was WHI, conjugated equine estrogens and medroxyprogesterone increased the breast cancer risk slightly after 4 to 5 years of use, but it was like 1 in 1,000 extra cases. It wasn't up like a rocket. But estrogen only, which was conjugated equine estrogen, it wasn't estradiol, was associated with a decreased risk to 7 years. And we think that the estrogen within conjugated equine estrogen, there was actually a SERM-like activity in it. So a selective estrogen receptor modulator, which was favorably affecting their breasts because there are a number of products in conjugated equine estrogen. It's not just one estrogen. Different progestogens do have different effects on breast cancer risk, with dydrogesterone and micronized progesterone potentially having a lesser risk compared with those more androgenic progestogens that were used in WHI, such as medroxyprogesterone acetate, which is other name is Provera. We do need to discuss breast cancer risk and VTE risk, and we need to document that in history, but it does need to be discussed in a way that the woman will understand, which it's absolute versus relative risk. So this was the WHI stratified by age. And you can see up the top, that was estrogen and progestogen together, and the bottom graph was conjugated estrogen alone. But if you look at the 50 to 59-year age group, which is the typical woman that you'll be prescribing hormone therapy, those absolute risks were not huge. VTE was the biggest risk, but you'll see there at the bottom, there was an improvement in coronary heart disease and an improvement in breast cancer for those on conjugated equine estrogen alone. But when we look at the older age women, the risk did go up with older age, and we're getting stiffer arteries, we're getting other risks more apparent in the other older age group. Remember that in WHI, their median age was 63 years, but they were aged up to 79. And I don't often start hormone therapy in someone at 79 years of age unless there's a very good reason for it. This was a Lancet meta-analysis looking at different hormone therapies. It scared us a bit because it was saying that, yes, there is an increased risk of breast cancer with estrogen alone. But it was important because buried deep within, it was looking at different types of progestogen and their risk. And you will see there, when something crosses the line, it's a null effect. It's no increase in risk. Within 5 years of use, you can see in the middle, dydrogesterone, micronized natural progesterone, and promegestone, which we don't have in this country, there was no increase in breast cancer risk within that time. But if you slip across to the right, yes, for more than 5 years of use, yes, there was a higher risk. So again, that's why we're tending to use progestogens that are more like the progesterone that our body makes. So micronized progesterone is the same, and dydrogesterone is very close. It's a retroprogesterone. It's just folded exactly the other way around. So when we're looking at breast cancer, this is a beautiful study that was done in France. 80,000 French women, they were all teachers, believe it or not. It's a lot of teachers, isn't it? And they were studied over time. They weren't all on hormone therapy, but they had questionnaire data. They got the women and analyzed them, those who were diagnosed with breast cancer, and they analyzed them by hormone therapy use. So again, when something in this graph crosses the middle line, there's no net effect. And you can see estrogen only, no net effect, and the orange box, estrogen and micronized progesterone, no net increase in breast cancer. They were on a median of hormone therapy for 5.8 years in this study. But when we look at oral progestogens that were not micronized progesterone or synthetic progestogens, that's where the breast cancer risk lay. But again, it wasn't extreme. It was increased, but it wasn't, again, up like a rocket. And this is a beautiful graph. There's a few of them around. There's a lovely one from the UK, which might be on the Australasian Menopause Society website. And it's got those beautiful little people. I love the people one, but it's a little bit of a busy slide for this presentation. So this is the cases of breast cancer per 1,000 women over 5 years for women aged 50 to 59 years in the UK. And I'm going to take you down to the bottom first. We'll go bottom up, with the general population having 1 in 7 cases of breast cancer from the age of 50. So it's 23 cases there. But if we go up to the yellowy orange bar just above that, using conjugated equine estrogens and medroxyprogesterone acetate, an extra 4 cases of breast cancer per 1,000 women over 5 years. Estrogen only, which is conjugated estrogen, 4 fewer cases in the yellow bar. We're now going to the mauve bar, having 2 alcoholic drinks per day, 5 extra cases. Smokers, 26, so 3 extra cases. Smokers get more symptoms and earlier menopause, a higher risk of premature menopause, and higher rates of breast cancer. So it's a disincentive if I didn't see one. But the major risk factor here, apart from family history and dense breasts, etc., was being overweight or obese. 24 extra cases of breast cancer per 1,000 women over 5 years. So I'm showing women this when they're worried about hormone therapy, and I'm saying, let's work on your weight or your smoking or your alcohol, or the green bar at the top, your exercise, because 7 fewer cases in those who exercise for 2.5 hours a week. That's 21.5 minutes per day. I think we could all do that, even if it's just running round the clothesline out the back, or running around or running away from our family or maybe our patients. We'd never do that, of course. VTE, this is the risk with different types of estrogens. So you can see here that transdermal estrogen does not increase VTE risk. So if you're worried about VTE risk because of family history, obesity, smoking, whatever, you can pretty safely use transdermal hormone therapy, whereas oral estrogen, whether it's estradiol or conjugated equine estrogens, does increase the risk, and it's dose dependent as well. And this was a nice study called the ESTER study, which was looking at different progestogens and estrogen as well. You can see the big bar on the left is oral estradiol, which is a huge increase in VTE risk in this study. And on the right side of it, estradiol and norpregnane, which is one of the progestogens we don't have in this country, but it's an androgenic one. They're the real increases for VTE risk. But you will see there transdermal estradiol in the light grey one, the second from the left, is right next to estradiol and micronized progesterone, which are very low risk for VTE, even though the micronized progesterone is oral. So it's fascinating what different hormones do with regard to metabolic things and for clot risk. So when we're looking at the benefits versus risk for women who do come to you with bothersome symptoms around the time of the menopause, I like to look at a sort of a scale type of thing. If they're perceived or real risk for cancer, VTE, or if they've got identified cardiovascular disease, if that stacks it down and it's weighing it down compared with their quality of life, their mood, their sleep, their vasomotor symptoms, their concerns about bone or brain, well, I would probably consider a non-hormonal option, but I'd make sure I'd give them some really good advice first and education, especially if they're coming armed with a whole lot of information that's not factually correct, because it's from these so-called experts out there, of which we have to bat off many every day. But if the women do have quality of life, which is terrible, mood is awful, they're not sleeping, their flushes and sweats are awful, their bones and brain are a consideration, and those real or perceived risks of cancer, VTE, and cardiovascular disease are lesser, then I would really absolutely consider hormone therapy if that was the right option for that person. It's about individualizing the treatment for the person in front of you, not like we used to give Premarin and Provera to everyone in the 90s because we thought it was going to benefit women somehow. The thinking has very much changed. I did say I'd talk to you about resources. This is one type of resource, but as you know, there are lots of different resources out there. I've mentioned the Australasian Menopause Society. I did note that some of you are our lovely members and could give this talk as well as I can. So welcome and hello to you. You know who you are, you too. But there are some beautiful information sheets out there, anything from calcium supplements to osteoporosis to SERMs. As I said, I did do the non-hormonal treatment sheet recently, so it does have fezolinetant on it now. There's anything from Fragile X. So have a look. We have some beautiful webinars. We have a really amazing congress. There'll be a lovely one next year in Fremantle in, I think, about the 14th of September. We'd love to see you there. And if you talk with your colleagues, you'll know that it's a very warm conference, networking, and we usually have dancing if that will bring more of you along. Pre-Congress update as well, which has a menopause essentials focus, talking about nuts and bolts of hormone therapy, talking about menopause, and talking about non-hormonal options as well. These are the what menopause info sheets, and again, beautiful, funny infographics on the left. I thought they were brilliantly done, but they are available at the Australasian Menopause Society. Sorry about the cuckoo, if you can hear that. And Jean House for Women's Health has some beautiful webinars in addition to the e-learning course, which I think is free for practitioners from now. So please book in with that if you think you need a bigger menopause tune-up. But there's some beautiful webinars there. I've just highlighted some that we've done, and you can gain access from anything from polycystic ovary syndrome, contraception update, vulval health. There are some others that aren't menopause focused as well. But I'm also going to highlight the Ask an Expert web page, which if you have a tricky question, go and have a look there because it might already have been answered. These were submitted by health practitioners around Australia, and people like Liz Farrell and myself have answered them to the best of our ability. So there's some beautiful expert advice there as well. The health ed meetings, I can't say enough of. I know it's a big day for you, 8:30 to 6:30, but there's some beautiful speakers, and I find those are really good quality of information and evidence-based. The Australasian Menopause Society Annual Congress, our Menopause Essentials update, it does go around the capital cities, and you can, as a member, you have free access to that. GPCE often has a menopause focus, your Congress as well. And we just had the International Menopause Society meeting, which 2,600 participants came to Melbourne or were online. It was incredible, but that will be in Rio in 2026. And they were very enthusiastic. I think if you want some fun in 2026, that's where I would be heading, and hopefully I will be heading to enjoy that with you. I'm thanking you for giving me the great honor of speaking. I know many of you are sharing this menopause world with me. It's a tricky one. It's been a pleasure to speak with you today. I'm looking forward to your questions, and thank you so much for having me speak today.
Thank you. Thank you very much, Sonia. I don't have any questions in the chat box, but if you want to pop anything in there, now's the time to do it. Or if you want to take yourself off mute, you're welcome to do so and ask Sonia any questions. While you're doing, yep, we do have a question. So I'll hand over to you, Anna.
Hi, Sonia. Look, I have a question about contraception at menopause. So women who are on a progesterone-only oral contraceptive, so either Microlute or Slinda, but have menopausal symptoms, can we just add in estrogen? And is that enough of a progesterone? Because we still need to provide the contraception.
We don't know. And I get this every time I do a talk on drospirenone or Slinda. I get the same questions asked. It makes a lot of sense because there is the hormone therapy product Angelique, which is a half a dose of that intraspironone, but we just don't know. The studies are not there. I suspect you can use it, and I suspect you're covered for the contraception and you're adding the estrogen back in, but we just don't have the studies and the evidence. So I can't comfort you this time, Anna. But it is being used. Your peers are
Yes.
doing it, but I'm meant to be saying it's off label and you've just got
Yep.
to counsel someone about it.
Yep, because I mean, obviously I use a lot of marinas, but if they're not wanting to have a marina, we still need to give a progesterone and they still need contraception.
It's a really tricky question and it's an off-label answer.
I do have a question from in the chat box. They're not sure if they've missed the reasoning for this, but why is clonidine no longer recommended as a non-hormonal option?
I know it's really disappointing because it's sort of our old friend. We've had it for years and it was the only one we had for a long time. Now we've got fezolinetant that are both for vasomotor symptoms and both are approved by the TGA. It's because the North American Menopause Society, which is our world's biggest society, I think it's now called the Menopause Society, looked at all the evidence and looked at all the reasons and what different products work for different women. And they decided that the evidence wasn't there, that it actually didn't benefit vasomotor symptoms. So they actually removed it to a lesser grade. So they're top ones that they recommend are grade 1 or level 1, and it is a level 2 option. So again, I think it can benefit a particular individual, and especially if we're treating the menopause and if we're avoiding migraine with it and we're treating their blood pressure, I can see the benefit there. So even though we don't recommend it as first line and it has been removed from that non-hormonal info sheet that we produce in a given individual, it's cheap and it's old and it's pretty easy.
Thank you. Another question. I often find it quite hard to encourage patients to try non-hormonal menopause therapy, especially when they've come in asking for MHT. Any pro tips? Thanks. And great talk on the end of that comment.
Very, very kind. So it's really tricky because I've had a whole raft of women, even after breast cancer, because there's some real cowboys out there saying, you can have hormone therapy. What's your breast cancer worry about? Just things that we wouldn't have even thought about. There's some very, very disturbing things. Like recently, there's been something about you can use estrogen on your face. It's about giving them the information and it's about weighing up the pros and cons. For example, giving them the Australasian Menopause Society info sheets on the hormone therapy, on the non-hormonal options. It's just about getting that trust and confidence. And some really really go with your recommendation. And I always sort of think that that's a lovely thing. Oh, doctor, what would you do if you're in my position? I know that's a tricky one, but it's just a matter of counseling them, getting the good information, and then saying, we're going to try this. Doing a menopause symptom score, I think, can be very useful. And then in 3 months reviewing it, oh, that wasn't so good. Maybe we'll try this thing. So that's often what I do as well.
Another question. Could you comment on the evidence of exercise and specific types of exercise on menopausal symptoms as well as other benefits?
I gave a beautiful, well, I thought it was beautiful. I do at the end of our Australasian Menopause Society Congress a clinical trial update, and I looked at the information for Pilates versus Zumba because I like Zumba and I like dancing. But this particular study showed that mood and menopausal symptoms were much better controlled with Zumba. They were better controlled on Pilates versus control treatment, which was no treatment. But the Zumba seemed to make people feel better and actually made their menopausal symptom control and their quality of life and their general health measures better. But again, it's whatever the person can do and it's what they can get access to, it's what they can afford. People who carry more weight, I say to them, you are wearing a puffer jacket. and you can't take off that puffer jacket, and that's what's causing more flushes and sweats. So just getting them moving might help them get rid of some of the puffer jacket. Those who do exercise more, it's better for their cognition as well. And just moving and getting out there, of course, better for breast cancer risk, as you've just seen, and better for menopausal symptoms. But it's good to say all that. It's hard to get them to do it.
Thank you. Is there any place for the use of tibolone?
Tibolone has a beautiful information sheet at the Australasian Menopause Society. It's a very funny hormone therapy. It's more a progesterone. It's a low-dose hormone therapy. It acts as an estrogen, so good for flushes. It's good for mild symptoms in terms of flushes. It's great for vaginal dryness. It acts weakly as an androgen, so it's good for libido in some women, and it protects bones. There's just a slightly higher risk of stroke from the mid-60s, but it's expensive too, is the other thing with tibolone. But I like having all these different boutique hormone therapies because, for example, if someone has lowered libido and not many flushes and sweats and maybe a bit of osteopenia, tibolone would be where I'd go to. It's quite good for vaginal dryness as well.
Is there a role for testosterone in managing symptoms?
So not for the guts of menopause, and the party line after a meta-analysis and consensus statement is that testosterone's only for lowered libido that causes distress. But some women feel sharper on it, they have clarity of thoughts, they feel better, they feel normal, and they like it for muscle mass and for promoting lean mass. So again, testosterone, I would point them in the direction of Jean Hales for Women's Health. There's a beautiful testosterone webinar there. Australasian Menopause Society also has a webinar. Get them informed, do a baseline level, and I would be doing it with close supervision using a female product. And there's one in Australia called Androfem 1%, starting with 0.5 ml to the thigh, making sure they can't get pregnant. That would be a bad thing to do on testosterone, and just reading them the Riot Act in terms of potential side effects. The only two irreversible ones are deepening of the voice and clitoromegaly, and they occur when our normal focus for testosterone, which is putting it to a peak female reproductive level of about 2.5 nanomoles per litre max. That's when people exceed that, possibly using a male product, and go into male levels. So safe use. The meta-analysis has said there's no net harm over time. The main risk is really excess hair growth.
Thank you. In what setting would you recommend non-hormonal options in someone who doesn't have contraindications to hormonal therapy, given the long-term benefits of estrogen?
It really depends on them. It depends on if I'm worried about bones, so I might do a bone density scan. I might ask about their family history. If there's a family history of heart disease, stroke, or bone density decline, then I'd be more likely to offer hormone therapy, because I know they're going to have this so-called window of opportunity, which means if we give hormone therapy around the time of menopause, rather than leave it many years afterward, they will get a cardiovascular and a bone protective and possibly a cognitive protective effect as well. So I think it will depend on knowing that person in front of me very well, but also knowing about their family history.
Thank you, Sonia. I don't have any other questions in the chat box. If anybody pop their hand up, if anybody's got any other questions. If not, could I take this opportunity thanking you very much, Sonia. It's always a pleasure, and you're so popular with our webinars. I've sort of had you over a few little times over my time here, so thank you. And please, everyone, fill out your survey, and if there's any other women's health topics you would like, we're going to run a series of them in 2025. Could you please pop that in your evaluation? I will now end the webinar. Thanks everyone for attending, and special thanks to you, Sonia.
Thanks so much. Take care, everyone. Bye.
Bye.